Good evening. Welcome, everyone. This is Lauren LaFave with Treace Medical, and really excited for the Mastery webinar this evening. This is the first time we are able to announce our brand new SpeedPlate rapid compression implant. So first webinar of this, we plan to do a series of these moving forward into the new year, featuring the new era in MTP fusions, featuring our SpeedMTP rapid compression implant. If you are new to our webinar, to the go-to system, you'll notice that upon joining, everybody is automatically placed on mute. However, we do really enjoy for these to be interactive, so we welcome all questions, comments to be typed into the chat box or the question box at the panel to the right of your screen. We'll be monitoring those and asking them as we go through everything tonight. And if there's anything that we don't hit on during, we'll save some time and have some time at the end to catch up on any questions and answer any further questions or address any comments that you may have. So we are very pleased to be joined this evening by Dr. Boyle out of Hyannis, Massachusetts, and Dr. Santrock out of Fernandina Beach and Duke University. Welcome, gentlemen. Thank you for being here. Cannot tell you how excited I am.
Good evening, everyone.
All right, and without further ado, I will turn it over to you two.
As per usual, we have to give a disclaimer that we are paid consultants for Treace Medical, and the opinions that we're going to express are ours. They did not proofread our thoughts, and we want you to make sure you're very well versed on all the literature available for deploying any of the products. And questions can certainly be answered in this conversation tonight, as well as further through your rep and through conversations we have available through Treace. Please refer to the websites and to your rep for additional information. Well, tonight we're going to cover some of the core principles of everything we've done at Treace, which is the Triplanar Philosophy, and move quickly into MTP fusion constructs and talk about the new Speed MTP. And James, I think you and I both can say without a doubt, we've been waiting for this for quite a while, an MTP solution that follows the Treace concepts. It's going to be an exciting new era. I think there's a lot we can talk about in the design as well as in the evaluations you've done early on, so that we can conquer some of these questions that I think are just going to be ubiquitous as they come in over the next several months. So with that, I'm just excited to get started and talk about where we got with this. This was not something that just came up, in the last year. Something that we added on to be a Me Too type product. If you've been following along with Treace all along, you've known that we have been able to think about bunions in a very comprehensive way. That went back to 2014 when we started together. We've listened to you, all the participants of these webinars. We've listened to you at our masters and introductory events, and had great feedback from many and most of you. And that's gone into the thought process and philosophy. It's not been something that we've just brought up out of thin air, and we've tried to hold true to our principles. This classification scheme was published several years ago now, was our thought process on how we started seeing bunions differently than what had been the classic, severity model and classic, hypermobility model. And James, what do you think about this now as we've evolved 10 years into the triplanar anatomic reconstruction of bunions? I still feel like we have huge gaps in our knowledge. I think we have huge gaps in our discussions, as well as, right now, still a lack of scientific understanding of what causes a bunion.
Well, I mean, I certainly don't disagree with you. I think one of the things that drew me to, Treace and to the Lapiplasty system and its concepts was the idea that this was, in fact, a complete correction. And it addressed all three planes. It allowed for much faster, fixation of these joints. It allowed for, I guess, what I would call surgeon-friendly application of these principles, and kind of taking them to an anatomical correction. And I think that's one of the things that really, drew me in as a user of the Lapiplasty. And certainly, my comments and my input on the design of the first MTP fusion plate.
When we talk about today's bunion world, and you're part of our family and philosophy of treatment, we're all focused on the TMT joint, but there's a resultant effect at the MTP joint, and unfortunately, many times that resultant effect is a malaligned MTP joint that becomes arthritic. And there also may be other conditions. I mean, it's this, when we start talking about MTP fusion, we're not talking about the old pure hallux rigidus, arthritic great toe MTP joint, it post-traumatic, post-gout. We're talking about the bunion that develops into arthritis. And so that's where this classification scheme came about. We immediately recognized that once you had arthritis, it changed your attitude towards the surgery. And you can see there, our recommendation way back when was talk about first MTP arthrodesis as your solution for that type of bunion. But we still needed to address the core principles. The 3D bunion surgery is still part of it. So even if we were going to do an MTP fusion, we're still thinking triplanar to get the deformity appropriately aligned to function biomechanically the best and we can, to streamline the foot, make sure it's sitting well in the shoe as well. With that, we did not want to sacrifice any of our instrumentation reproducibility. And with the Lapiplasty, it became the instruments were most important first because we didn't have a good technique for Lapidus. And the hardware became secondary. Now we're going to talk about MTP, almost where the hardware is the primary source of our innovation. And the technique will follow as we develop instrumentation for reproducibility over time, which is already in the works. We've been very fortunate in the last year, James, to have the SpeedPlate deployed, and I'd like to have your opinion overall of the SpeedPlate platform, which we're going to show adapted to the MTP. You've used it, you like it? Is it an improvement? Is it something you see continuing on in the future?
The SpeedPlate is an absolute game changer. I was very happy with the Lapiplasty system in general. I thought the dual plate system that with individual separate screws that we are looking at right now on the right of this slide was great. It was relatively straightforward. I thought the instrumentation was easy to use, but the SpeedPlate just takes that to the absolute next level. The ability to look at where you're putting this, the ability to appreciate appreciate where the tines of the energized plate are going to end up, where the just to make sure that you're in the right section of the bone, you're in the strongest section of the bone, you're where you want to be as far as the joint line is concerned. It's been a game changer for me. Not only I would clearly say it's been a game changer for me, not only in the sense that patients tolerate it better at the TMT joint, both medially and dorsally, but they're just healing remarkably well with it, and I'm not losing any fixation. I've had no plates elevate out of the TMT joint, especially dorsally, which is where you usually look for it. So it's been an absolute game changer as far as speed of surgery goes too.
It's very broadly used over the last 10 years now, and we've studied it in prospective studies as well, and the biggest thing that we took from that experience of the individual plates and screws was apply that, what works, improve upon it with the SpeedPlate. So you can, those of you that are new to SpeedPlate or have not even heard this at all, or just to reiterate, especially the quad SpeedPlate design was directly built off of the Lapiplasty plate. So I think that leads us into a really great place to say, now, can we apply that to the MTP joint? Lauren, you can advance, so MTP joints, I'll let you go ahead and make comments here. I mean, the variety you see in your practice, James?
Oh yeah, without a doubt. You were mentioning before the idea that this isn't just the most of the MTP fusions that we see in a lot of the the studies that are 5 or 10 years out type studies. This is things in my practice that are look a lot like the image on the right. That just make you shudder a little bit when you first open the screen to look at the X-rays. But you're also looking at increased DMAAs, and you're looking at metatarsus adductus, and you're I think that there is a huge variety of pathology that goes on in malalignment that we need to talk to our patients about, and MTP fusion as an option for.
Yeah, I had an interesting case today brought to me by a colleague for a peer consult, and Ehlers-Danlos failed distal procedure, was basically a silver bunionectomy with a soft tissue balancing, and it failed. And had a very slight metaductus, not severe like the right-hand picture. Already had a little bit of navicular cuneiform sag, and we really had a long conversation about whether the MTP joint fusion should be done instead, and whether it should be done maybe in combination with also additional surgeries. So the MTP joint fusion is a workhorse in those of us that have marketed ourselves towards bunions. You'll find that we're doing a lot of these. Paul Dayton says he does 50% of his bunions are MTP fusions. I don't know if mine are that high, but they're significantly high. A third probably are the patients that come in. I live in a retirement community, so it's easier to please a lot of patients with an MTP fusion, even though my weight-bearing scenarios are the same. So with this type of system, and I've been doing currently the biplanar quad SpeedPlate at the MTP the last few months, and very pleased with it. Like you said, I believe I'm seeing a very quick, robust healing. Maybe it's me trying to lay eyes on it. We haven't studied it very long yet, but to me it seems fast. See, and so I want to believe that. I hope it's going that direction, and that's what we're trying to build into this. Next slide. You know, today I had to go over a case with a patient using the algorithm. I took this algorithm and put it in layman's terms, and still I use it to illustrate to my patients, and I give it to them. And she was this exact patient. She was complaining about a bunion. She had evidence of arthritis, degenerative findings at her MTP joint. She did not have metatarsus adductus, and so I just went down the line and I said, these are the most appropriate Lapiplasty family surgeries that we have, and the MTP fusion was what I was leaning towards. How do you like this algorithm? Do you use this algorithm, James? It's not comprehensive for every scenario, but it's a pretty good basic starting point for most cases, I think.
I agree completely. I think it's I mean, it's probably something that's been part of, my rationale for a number of years without having seen it, because it's a very logical flow to this algorithm. And I think if you are, in a situation where you're, I guess, equivocating between the two, options for the patient, this is, or you have to explain it to the patient like you did and say, hey, listen, this is what has been shown to be the best thing for you. It's definitely useful.
And
one of the other group of cases that I see a number of are the old, people who had an old McBride done years and years ago, and they come back and a third of the head is missing. And correcting that is completely, it's going to leave them in a bad spot. And so that's another, kind of post-surgical. The only thing I would add to this is post-surgical.
Yeah, that's a good point. What you notice here, those of you who are new to seeing this algorithm, is that OA, or our degenerative changes, is the first question. And that's how important it is, because what we've noted is that if there's degenerative changes in the MTP joint, I have to now talk myself out of doing an MTP fusion of some kind. Now it may be combined with other surgeries, but and I had that conversation today with that peer I was talking about, that once I have that, it's everything it takes for me to say I'm not going to fuse the MTP joint. And a lot of people ask, how much arthritis is too much arthritis? Well, there's no real way to say one single answer for that, but I will tell you this: once there's arthritis evidence, either clinically or radiographically, you're in jeopardy of not having a satisfied bunion correction, whether that's due to erosions and instability that will be therefore, or stiffness or pain. So it's really important to clinically evaluate and come up with your judgment on that. And I'm pretty critical. I'm pretty aggressive at clinically evaluating the patient for arthritis grind on the exam, as well as sesamoid pain. So any tricks you have on deciding that, or are you aggressive, or do you let that come about later? How do you go about it?
No, I'm pretty aggressive with it. Living on Cape Cod, we have a pretty high number of retirees up here also. every 6 months, 50 to 75% of them go down to you. And then they come back up here in the summer. But it's I am very aggressive with it. I would say that my numbers percentage-wise have to be high, more toward Paul's numbers as far as what I offer. I've always called myself a kind of a one and done type surgeon, and you wanna offer somebody the surgery that's going to give them the best outcome. Now you take a 25 or 35-year-old woman who's a runner with a bad straightforward bunion with no metatarsus adductus, you're going to offer her a Lapiplasty. But when you have that 65, 70-year-old patient who's coming in because she's getting, some skin breakdown medially, and she does show evidence of, even mild changes. And one of the things that I've begun to really be hypercritical of on the imaging is that, lateral view of the foot to look for, and the oblique view of the foot, because the rotation of the fibular sesamoid, you're getting almost like an en face view of that fibular sesamoid. So really being critical of whether or not there is osteophytosis at that fibular sesamoid and at that tibial sesamoid on the lateral view, I think is hugely important to guide your exam when you're in the room and push on that area, and not just focus on the the dorsal aspect or the medial aspect, because I couldn't agree with you more that when you correct the IMA on somebody who has, mild to moderate or even just a little bit of arthritis in there, it's going to stiffen up.
Indeed. And, I think one of the big fears that I hear from surgeons, or I should say a big comment I hear, is often you'll hear, there's no way my patient will do a fusion. They don't want a fusion. And I'm always kind of baffled by this. I feel like you're probably the same way. I don't tend to offer patients what they want. I offer them what they need. And I can say that boldly, and right as I'm standing here commanding a webinar with you. But the point of it is that with this algorithm and other visuals that I use, I have trifold information things that are available through Treace for each of these surgeries. And I show them the algorithm. I point out to what findings led me down the path, and I say, this is what your bunion is like. And I point it out on the x-ray. And I often wonder, when I tell a patient this, I don't have people kick back and say, I don't want a fusion. I'm not saying never. It's rare though. It's a rare circumstance. Like, well, I'm a ballerina and I don't want that, kind of thing. But it's not, once you tell them the logical patient, the logical thing, and show them visually, I don't get the pushback. And I wonder if more of our colleagues would take that approach and saying, using the visuals and also using creative words that help them understand. I often say you have a bunion plus. It's like Disney plus. Yeah, you get more. So
yeah, well done. I think you're absolutely right. I think it's important to ours is not the place to make the choice for the patient. It's to me, it's to educate the patient and let them make a decision. But at the same time, you have to weigh in with what your strongest recommendations are. I find it useful to kind of have a couple of studies in your repertoire to refer to and talk about one or two statistical figures that you can share with the patients regarding return to activity and outcome satisfaction, and when you break it down to, hey, we can correct this by fusing one of two joints, TMT or MTP. If we do the the TMT, yes, it's going to make it straight, but it's very likely to depending on the anatomy, increase your risk of recurrence, and B, increase your risk of continued pain at the MTP joint, and that that could mean a further surgery. And so I find that when you break it down that way and just kind of lay it out, and I agree with you that I get very little pushback on it.
And we're very fortunate Treace has allowed us to do a lot of studies. And those of you who are interested, there's a whole portfolio of the studies that we've been able to produce data on the Lapiplasty systems. That will continue on with the MTP as we now start gathering data with the systems proprietary to Treace. So, constructs have varied over time. I mean, James, you and I are probably both old enough to know that we started off doing this without a cup and cone reamer. They may think we're dinosaurs, But I learned on flat cuts, and they tell you what, if you were good at it, it worked really well. And I started off with screws quickly right after my graduation time, which was 2002. Pretty much by that point, dorsal plating was, was not sophisticated at the foot and ankle yet, but it was, we were using dorsal plate with an interfragmentary screw, and then quickly came the research that say that's a pretty good standard. And now I've progressed on, but I'm doing that double quads to the right at the moment, getting ready to switch to my Speed MTP. But have you been through this pathway as well?
I have been through everything on that image in front of you, except for those staples, second from the right. Staples are one of the things, the old school staples are one of the things I certainly stayed away from. I grew up, quote unquote, trained with Myerson down in Baltimore doing the cross screw construct. They had not moved to the dorsal plate, although there were certainly, I think, a few systems out there at that time, and we were using a burr. I've only done flat cuts in my practice, usually as a necessity when I'm revising someone else's failed MTP fusion. But I got away from crosscuts relatively quickly to the construct that looked a little bit like the one from the second from the left. And that I used for probably a good 7 or 8 years. And then I started using a nitinol staple in the middle of a plate from the Crossroads system rather, and that's what I'm now kind of getting away from, simply because I've seen just too much rapid successful healing out of these titanium speed plates that we're using. The technology is just fantastic.
That dorsal plate crossing screw or dorsal plate with the compression staple has become, universal. I think probably everybody that's listening today would say that they're using some variety of that or had some variety of that being used at some point in their practice. And so it's very familiar. So that familiarity of that dorsal plate and some other compression augment was appealing to us when we wanted to design our system. What was, I was using the biplanar plating and went to the biplanar speed plates, but I was still using a ton of dorsal plates with interfragmentary screw because I had two different clinical scenarios where I didn't have availability of the biplanar plating at a facility. So I was defaulting to a titanium plate dorsally and with or without an interfragmentary screw. And I have good luck. It's good. Now the speed plates seem to be much more robust, much more rapid in what appears to be radiographic healing, speed to radiographic healing. I'm like you. I never really used the nitinol. But one thing for me personally that I wanted to see evolve from the speed plate application or the biplanar plate application was the bulk of the metal. And to me, I wanted the lowest profile implant that could ever be thought of that could be strong enough. And that's what we went into with our design. So, that's what was not just my desires. They surveyed users out there as foot and ankle surgeons to find out what was their biggest complaint with the systems they have, what was their biggest compliment to the systems they have. You can see that simplicity was the #1 reply for what was good with the systems they had, which that tells you, MTP is familiar to us. We all do it well, and we all have basically systems that are relatively straightforward and easy to use. The dislike mostly came around the bulk of the metal, the bulk of the implant, hardware prominence, any other way you want to talk about it. Other things that were, discussed in this with the replies came about, a need for compression. Some people still want either some high volume of compression or at least the understanding of compression. Joint healing visibility on x-ray was something they like to have. Allow for early weight bearing. And, the cost also comes into play here. So this was a pretty good survey. It seemed to match all the thoughts of the people in the design team and with the bulk of the people that were doing early evaluations. So anything to add there, James? Sorry, I'm going to default to Jim. I know that's such your name.
No, that's quite all right. I'm at 53. I'm getting pretty used to it. I think this was one of the when I initially was contacted regarding kind of weighing in on evaluation of the earlier designs. Bulk was one of the major things for me, and I think that's you just have, you have to think of who you're doing. I mean, the fact is the majority of people that end up with either hallux rigidus or, any level of arthritis from other deformities that require this treatment, these are older people. And so they're not, they don't have the most supple skin. They don't have the best skin. So, the response of Treace to address that bulkiness and yet keep the rigidity and all the other features of the system that we're talking about tonight was great. I was very, very impressed with how they took this this feedback into account.
Yeah, and that, when you talk about bulk, you're talking about more than just the thickness of the plate. You're talking about the design of the edges of the plate, everything else. Well, as you can tell, the Speed MTP looks like the SpeedPlate in the sense that it's a drill straight and deploy a compression activation across the bridge of the plate. In this case, because we were moving to a single plate, we thought it was appropriate to also add 2 additional screws that were 25 degrees off axis and to assist in helping us have more than one plane of control. The system was supposed to be designed with all things encompassed. We also wanted to know, can this stand alone? Do we need an interfrag screw? We're moving from biplanar plating in this sense to single plate, control. But we have a lot of experience with this at this location with single plates. So it combines that speed plate with the fast pitch. James, did you use the fast pitch screws before you got to the speed plate period of time?
Oh yeah.
So,
you mean for the regular Lapiplasty system?
Yeah, so that they compressed down that plate a good bit. That's where the speed plate really was designed from. And then you get this same energizing or the arcing of the plate. Now it's not exactly the same as a speed plate. You might even see directly up here on the images, it's a little bit less of an arc in comparison to the speed plates that we use at the TMT joint and at the other midfoot joints. And that was by design. It was something we had to really play with. You can imagine too much activation can cause plantar flexion, too much activation can cause dorsiflexion. So this was worked on heavily by the team of engineers. I don't know how many engineers are at Treace now, but it's a whole bunch of them. And this took a lot of work to try to get the same amount or a near equivocal amount of dynamic compression, as well as, but watch the movement and prevent sagittal plane malalignment. It is 1.3 millimeters thick, which I think is the thinnest plate available at the present time for MTP fusion. But the edges have been what's called infinity edged. So they're really sloped in a much more gentle way at the tips and around the edges to give you a less profile off the edge of the implant, which is really important for soft tissue irritation. And then the shorter legs are placed at the farther ends and allowing the maximum amount of bone purchase in that shape of bone at the MTP joint, but a gap left in the middle that allows for that ball and socket to fit without getting into the joint. So to me, there was basically what we asked the engineers to design was give us a speed plate functionally, but give us all the best features of the dorsal plate now. Make it smaller so we can see around it on either side and see the joint healing. Make it go in fast. Leave us enough room to get the joint together. And it comes in a standard and a large. So the standard, I think, is going to be the workhorse. We'll see as time goes by. There's not a huge difference. There's a couple millimeters in the gap in the middle. And I kind of think of them at the present time without deploying them yet as kind of like male-female, is how I'll probably, go into it looking and sizing it up. Nice thing with this, James, as you know, we have a drill guide, so you don't have to pick the plate just out of the air. You can hold this up and see which fits better for your situation. So you've seen these instruments, you've done you've done.
Sorry, I was just saying, I love the design on the bottom of the guide, the drill guide, because it's essentially just like the plate. It's got those tines cut out in the middle there, so you can centralize your joint when you're actually looking at it before you drill in. So it not only the the ability to see the joint when you're drilling through, but just being able to see how that plate is going to fit on there, make any adjustments as far as taking down bone, to kind of make sure it's flush.
Absolutely. And the SpeedPlate will come with 5 screw options for your off-axis screws. So you have a choice between screws or where you're located on depth and whether you want to get unicortical, bicortical. You'll have a selection from 12 to 20 on your length of screw. And I think that gives you a little bit of variety and variability in the type of fixation you want to get. Are you bicortical now with a dorsal plate, or are you unicortical with locking screws now that you have this combined staple as well?
Well, the answer is yes. I do a unicortical screw distally, and I do a bicortical screw proximally.
Yeah, when I'm going without any kind of interfragmentary screw, I tend to go bicortical where I can, and then if I have an interfragmentary screw, I'm comfortable going with just unicortical screws with a locking plate. But again, that's on my own. Half the time I'm using the Treace system, and I don't bother worrying about it. I would say unicortical because it's been biplanar. So this gives you options for what people feel comfortable doing. The kit will be somewhat simplified. You will have reamers available. It's not have to ask for additional reamers. Those of you who don't know, the reamers have been available for a very long time. And you'll have your all the equipment you need to deploy the system, including there will be options for the interfragmentary screw. As of right now, that is not packaged in the same system because we're going to see what people tend to do. Lapiplasty users may not be using the interfragmentary screws, and those traditional dorsal platers may. And you'll have an option to have that come with 3 sizes available. We've done a lot of work trying to do that. The nice thing is you won't have a huge variety because we've been working on targeting for this. The targeting system is not fully released yet, so those of you who are going to be doing this in the first few weeks to months, you won't have the targeting guide, but we have been working on a targeting guide to avoid the SpeedPlate and to place the screw without causing any interference. Now, personally, myself, I think the screw is more like a neutralization screw as opposed to a compression screw because I'm getting compression through my plate. So that's something that's going to be a conversation as time goes on and see how people do it.
I think the idea that there were, sorry, go ahead.
Oh, go ahead, Dr. Boyle.
I think the idea that we have those fast pitch screws coming in at that 25-degree angle and creating that multiplanar fixation for me is it's going to add a significant amount of stability to my construct because I don't use an interfragmentary screw now. I think that this is that is going to, I think, convince people to go without that interfragmentary screw or feel more comfortable if they decide to.
And your benefit of no interfragmentary screw, you told me the other day, more surface area to heal, right?
Correct. We're taking this. I think it was Mindy that I heard at one of the conferences say that she likes to take the metatarsal head down to almost the diameter of the shaft, so that this is a kind of a fully decompressed site now. When she's fusing it, and if you do that area that you're, especially in some of these smaller women, the surface area that you're getting apposition of the bone surfaces is going to be relatively minimal. So you want to kind of allow all the surface area you can.
I agree with that. It's done well with the biplanar plating. So if it turns out we have that kind of stability, we don't need it. I agree. More surface area, the better. James, you've gone through the independent of the design team and evaluation. You want to take us through the technique here?
Sure. I think obviously the cup and cone reamers come with the set. I've been a cup and cone reamer person for a number of years, probably well over 10. Very few incidences, very few complications using them. There's a learning curve. I think you just need to get used to them. Go easy when you start is all I would recommend. I always start on the metatarsal head. My go-to is about a 22 millimeter cup reamer over a guide wire. Generally try to, just get the guide wire in center to the shaft. Try to, almost ignore what the head looks like at that point so that you at least are reaming this thing evenly. You obviously have the option of moving it in any plane you want to once the surfaces are made symmetrical. So cup and cone reamers on each side, always high level of caution, reaming the proximal phalanx because of the change in the density of the bone right underneath that subchondral bone. You're going to, at that point, irrigate. I think this is one of the things that I can, I used to fenestrate with the wire, the guide wire for the cup and cone reamers. And it was the, kind of the technique of utilizing a small drill at the TMT joints. I've moved down to the MTP joint. So now I take my wire out completely, irrigate out, and then I'll fenestrate with usually a 1.5 millimeter or a 2 millimeter drill to produce some graft, pack it in there, and then place the joint into what I like to dictate as an anatomically acceptable position. And throw either one or two wires across. You can see in the picture on the lower right, you've got two crossing wires to maintain stability. And then your technique guide, or your
Dr. Boyle.
drill guide. Yes.
So just as it kind of pertains to joint prep, there was a question that came in, and before we get into the actual Speed MTP component, question came in, how do you determine if and when you remove the sesamoids during your joint prep or prepping for your case? Have you had to return to surgery to remove one or both of those? And any comments on the Krista?
Yeah, I think the best, in my opinion, how much bone I take from the metatarsal head really determines the tension of the soft tissue and the severity of the valgus in those situations. Obviously, when this is a straightforward MTP fusion for hallux rigidus, oftentimes the overall alignment is not really out of plane, and so you don't have to worry about skin tension. But when you're correcting a severe bunion like the one we saw in the earlier radiograph, you have to make sure that you are taking a little bit more bone so that your soft tissue can tolerate the amount of straightening, especially the EHL, because you want to have a little bit of kind of tension off of that when you bring it out to the position that you're going to fuse it in. At that point, after I've reamed my first metatarsal head, I will look right in there and evaluate whether or not the sesamoids are going to create pain. Do they have severe osteophytes hanging off? And B, are they going to impact my reduction of the or my apposition, I guess you could say, of the phalanx to the metatarsal head? And I've seen that sometimes where you feel like you're pushing these surfaces together, and it's like they won't go together. And oftentimes that's because of the distal aspect of the sesamoids and the osteophytes associated with it. The other time that I've run into issues with the osteophytes, with the sesamoids rather, is after I debride a little bit of the fusion's done, and I just take a microsagittal saw and I'll debride some of the medial side, basically just to bring it to a smooth, rounded, if it's a severe bunion or just a flat surface, and if the tibial sesamoid then sticks out past that flat surface, mostly because of osteophytosis or just because of a large sesamoid, I'll take it out then. I have had to go back in and take out 2 fibular sesamoids over the course of the last 10 years, 15 years, but very, very infrequently do I have to go in and take them out. I think it's more just an awareness of them and the ability to trim them down or resect if it's really in the way.
Yeah, the one thing I would add to that is that I think one of the big fallacies that people have with MTP is a lack of good visualization. This is an aggressive, opening of the joint, and I use Maglamry elevators. We're working on some specialized tools for that. The Maglamry elevator is really aggressive to get this all broken loose. It's not always bone. It's sometimes just a fixed, scarred in soft tissue as well. Those sesamoids need to get mobilized off the head, fully prep the MTP joint position where it wants, then the sesamoids can settle back into the appropriate position. So I would also just say, pay close attention to how much this is. And limiting your visualization is not very good with this procedure. You really need to have this fully mobilized to get the toe to position where it needs to be. So that would be my only addition to everything that James said about says one.
Yeah, the McGlamory, I agree wholeheartedly, is a huge, hugely important tool. I think it also can actually lend a lot of help with just getting the phalanx out of the way when you're putting that cup reamer down over the metatarsal head, and protecting the surrounding bone and soft tissues. Bob, you can weigh in on this, but this incision heals incredibly well. I mean, I've had, knock on wood, very few issues with, wound. I don't know that I've ever had to take out hardware because of a wound, breaking down. This incision heals very well. I usually, try to do, subdermally. I go almost right down to bone. I try to create full thickness flaps and, open the joint up as well. Just to kind of make sure I'm seeing everything.
Yeah, I agree. The only time that I have trouble is when hemostasis wasn't good enough. I've made that mistake, or I've had patients on the popular things like fish oil and vitamins and such, as well as other anticoagulants. And so you got to watch the hematomas, see them quick and fast. And I haven't had to take any hardware out, but I have had to nurse a hematoma or two away. And I think if I was more careful, looking for bleeding and being careful to get those cauterized if they're there. But I agree with you. This usually is a scar that heals beautifully, fast, rapidly, and I do a full thickness approach as well.
Yep. So I'll keep going after you get that provisional fixation with a couple of or a single K-wire. Again, that guide has those nice little I guess you could call them arrows in the center to kind of put on the joint. This shows a good example of needing to kind of find a flush surface there. You're going to hold your guide in place. You are going to provisionally hold it in place with in those two little tack holes on the medial side, and then you can get an X-ray at this point and look at where your holes fall. You can adjust this if you want to. I don't know the exact diameter of those wires that we're seeing put in there. It's probably no more than like a 1.4 or 1.6, I would imagine.
Yeah, they're 1.6.
And then, yep. And then, you're clear as far as your crossing wires, if you choose to do so, or your single wire, if you choose to do that, as far as, putting your drill in. So, and then
again,
you would drill all 4 holes.
Some additional things coming, targeting devices coming, positional devices coming, things we've been working on. We know we all have been there, frustrated with trying to get the position just right. Throwing K-wires can be frustrating. Just like Lapiplasty, we've automated a lot of the steps. You'll be getting that in the future. It's been worked on. We have lots of things in the works and passing through. So you're going to see them deploying throughout the year as the instruments become available. This plate can be placed medial or lateral with the tacks. It does not matter. It's universal. I think most people are going to place them medial because it's going to be the open side to be working from. But the truth of the matter is, if you like them hidden over on the lateral side, let's say you have a narrow bone, narrow foot, you will try to get those lobes over laterally. That's perfectly fine as well. It's really designed pretty low profile, so I don't think it's really going to be much of an issue. So just wanted to be aware that if you see pictures come out of this or other people using it with the screw up caddies on the opposite side, it's designed to be universal.
Bob, while we're at this point, obviously, after your provisional fixation goes through, you want to check your alignment. How do you choose to judge your sagittal plane alignment?
So for me, it's almost all clinical. I mean, I use a flat plate, hold it up to the bottom of the foot, and I want to see the tuft of the skin depressing on the plate of the tuft of the great toe. I want to be able to easily pass a freer under there, so a standard freer, and it should deform the skin but not be so resistant with gentle pressure that I can't pass it through. And of course, if it's not touching, then it's too high. I definitely don't want anything at the proximal end of the hallux to be touching. So at the IP, being proximal to the IP joint, that can't be touching the plate. That's my number one thing. Of course, I want the nail parallel so that the rotation's correct, and I want I try to make it straight with a triplanar correction if at all possible. There are times where I leave it in slight valgus, But I do check a lateral x-ray, but it's almost useless for me because I really don't ever use that to make a decision. But when I do look at a lateral x-ray, I'm shooting for the inclination of the metatarsal to carry on through to the dorsal side of the phalanx. So to me, I'm making a straight line. And that goes back to 2012 when I wrote a paper about dorsiflexion in the implants. And back then, in the early 2000s, 2010s, almost, and still on today, almost every implant company had a straight plate and they had a dorsally inclined plate, dorsiflexion 10 degrees or so built in. And when I studied that and found that there was a lot of mistakes being made, the technique guides all back then were written, use the plate as a template, then fix with a screw and then secure the plate. The problem with that is it builds in 10 degrees of dorsiflexion, whether you need it or not, number one. Number two, it's also very, very sensitive to the distance from the joint of where you put that bend. And the center of the joint wasn't the center of the plate. So people were typically putting it proximal. And by putting it proximally, dorsiflex. And I can't remember the exact numbers that I had, but essentially if you moved it a millimeter, you dorsiflex 3 to 6 degrees. So if you move it 2 millimeters proximal, you're dorsiflexing 6 to 10 degrees. And so this is a big problem, right? So if you think you're using the plate to give yourself a good alignment, it's really giving you a false sense. And that's also a problem with the cup and cone reader, because as the phalanx cups over the cone of the met, you think the joint line is more proximal than it is. It's not. It's more distal, hidden inside the cup. So people in general were putting the plates on too proximal and then getting these dorsiflexion deformities. So, over time, the dorsiflexion plates have fallen out of favor for the most part, and the vast majority of them are straight. And the straight plates tend to work the best and give that performance that I said clinically is what I'm looking for. And so by tacking this on and I check it there, or I do it with my K-wires before I tack it on, that's what I'm looking for. Is every single one of them zero? I don't think so. There are some with a cavus foot where it is dorsiflexed a little bit, but I still use the same principle. And that's why the lateral x-ray doesn't really do me a lot of good, because I'm actually looking at it clinically. But it's interesting as we move into this, design system for MTP, that we'll get a ton of feedback and tricks from everybody around the country and see where they're at on this. But that's where that came from.
Yeah, I use a flat metal tray also to evaluate, and I'm looking for nearly the exact same thing. Touching when I put it up passively, and the ability to flex the IP joint down passively and get a good contact with the metal tray.
Yeah, I think, and when I was a board examiner, if they did not tell me they clinically evaluated the MTP joint position, I would ding them one for that. I don't know if I failed anybody. I doubt that. But I thought that was a clinically, I thought that was a crucial thing if you were doing MTP joints. And I think it's crucial to put in your op report that you clinically evaluated it in weight bearing position. That's far more important to me, that you did that correctly, and it will protect you in lawsuits and everything else that you did it correctly. So it's the right way to do it.
Absolutely. So you can see the image on the left is drilling into the now verified open holes without contacting any of the wires. The fixation of the drill guide down is following the plane of the screws that are going to be put in. This installing device, I guess we could call it, is lined up with those holes that you used to hold the drill guide on. This technology, or this technique, is very similar to the SpeedPlate in the Lapiplasty. You're pushing it in as far as you can, malleting in. I'm a little bit of a voodoo kind of person. I energize the plate myself. I don't want it done surgically or pre-insertion. I energize it right before I put it in, and then I release it. Those gold drill guides are for the fast pitch screws, and so after the drills are passed for those fast pitch screws, you can remove those gold drill guides with the golden retriever. which is that wrench right there. And then those open slots, you see the green screw going in, act as almost a targeting guide to make sure that your fast pitch screw is going to lock into the plate flush and well locked to the plate itself. And then
So
you're going to release that. Go ahead.
A couple of design features here that were unique to the MTP. You can see there's a thumb hole in the inserter device, unlike the regular SpeedPlate. That's because we're working at the end of the foot. You needed a little bit more control. So the other thing is that if you picked up on when you evaluated it, James, was it inserts a little bit more easily than a SpeedPlate, less resistance, drilled purposely, a little bit more closer to line to allow for this more finer control at the end of the foot as opposed to robustly in the arch of the foot. So a few of those things, design features purposely put into this to help with the ease of insertion.
Yeah, there's no doubt that pushing it in by hand, I think you can get, you're dropping it in 80 to 90% and needing to mallet very minimally.
You still have to hit it with a metal mallet to be sure you're doing orthopedic surgery, but it's just
I do love the design on the that inserter handle. It's the same concept. You're gonna pull that inserter handle out and use the end of the inserter handle to actually remove the locking towers for the plate itself that helped with the energizing. I will say that the even the cadavers we were using down in DC, the rigidity of the construct after those fast pitch screws went in was impressive.
Yeah, it's pretty exciting. Every time being able to have a practice that's had a split location availability, even though I'm on all the design stuff here, it's been neat to see the difference between a SpeedPlate construct of any kind, including MTP now, compared to, a non-Treace product. It is, just like you said, a step forward. It's something advanced that's in multiple different ways you feel more confident with. That's
absolutely. I've made the jump to using speed plates in my tail and navicular fusions, navicular cuneiform fusions. They're just they're great. They're so easy. They're nice and rigid. They're fast. It makes a huge difference.
Well, we've covered a lot of the frequently asked questions, but we'll just repeat them here. Preset valgus and dorsiflexion. We talked about dorsiflexion extensively. Both James and I are on the position that the plate being straight helps us the most. You can continue to talk to us in peer-to-peer situations for that. As far as preset valgus, I will tell you that I'm not of the school that I have to have it 100% straight every time. There are times when I'll leave a little bit of valgus in for the contour of the foot and for the, what I have to work with. If I have slight metaductus, if I have, a gap between the toes, and I'm not doing a full reconstruction for whatever reason, maybe it's an older patient. So, I think that's dealer's choice. The other interfragmentary screw use, this is going to be dealer's choice. You heard the argument by James to say surface area matters to him. I think we're going to obviously feel out the stability of this. I've been doing non-interfragmentary screw with 3 locking screws on either side of a dorsal plate that isn't as sophisticated as this, that doesn't have active compression, and I've been able to do it fine without any complications. So I think that's probably James, that's your experience as well, and I think we can say that it's going to be up to you if that's what you want. We will have techniques available and instruments to aid you so that the speed plate still continues to be easy. What's my post-op protocol? All of my Lapiplasty surgeries, and this is one of them again, I compare MTP fusion the way I do it and the Lapiplasty family of surgery. So they're all the same for me. They all start weight bearing the day after surgery. Why the day after? Because I can't do it the day of, not because I wouldn't. It's just because I don't give them the boot and they have had anesthesia. So I just bring them back the next day to pat them on the head, tell them everything, their surgery went great, show them pictures, and I start weight bearing that day. Now, to me, weight bearing is limited to bedroom to bathroom, couch to kitchen, and bedroom and curb to door for the first 2 weeks. And the only reason I do that is so that they're resting, icing, and elevating. But I do tell them to get up every hour and move around. pump that blood out of the bottom of the foot and put some weight on it in a boot. And I wear the boot for 6 weeks. Now, I will tell you, really, my MTPs, they're not a full boot. It's a post-op shoe for the most part, is all I use there. What's your post-op protocol, James?
I am a 2-week non-weight bearing person, especially in my younger patients. If I hit that 75-year-old who's got terrible pain and we decide to move forward with surgery, I'll often just do exactly what your kind of standard protocol is, and I'll just say, hey, listen, I want you to hang around the house for the next couple of weeks, only walk around as you absolutely need to, and use a walker to bear most of your weight. But yeah, I follow the same protocol as my Lapiplasties. I do keep them non-weight bearing for the first couple of weeks. I actually put my Lapiplasties in a single slab, posterior slab Jones splint, just to protect the soft tissue. And I put my MTP fusions right now in a Darko wedge shoe, and I just ask them not to walk on it. I'm sure probably 30% of them ignore me and walk anyway. But yeah, and then after that 2-week period, they come in, they get their wounds evaluated and stitches removed, and then they can start, weight bearing a little more normally in the Darko shoe. And then I just end that at 6 weeks.
I want to throw out a caveat that when you hear me tell people that they walk day after surgery, is that I have a boutique practice in the sense that I'm in a low volume, high touch concierge type practice, in the sense I see my patients every week or sometimes more than once a week, to hold their hands and to tell them everything's beautiful. So by me, that allows me to observe them a lot more than you do in a standard practice. So I feel comfortable weight bearing them because I'm seeing their wound every, 3 to 7 days, and they're swelling every 3 to 7 days, and changing their dressings myself. And I do it for, customer service. There's no medical absolute need for it, but it does allow me to observe a lot more so that I do feel comfortable. So if you're going to move to this immediate weight bearing scenario, I do think that a smart thing is to see them more frequently, because if somebody's getting too swollen because they're being too cavalier and they're not propping their foot up and icing and elevating, then you'll know quickly. So I think that's what I hear a lot of people say is, oh, if I let my patient walk, they'll do too much. Well, that's probably true. So one way you can counter that is keep them off of it or slow them down, or you can see them really frequently to know. So.
Agreed.
What's next?
Very much. Yeah.
You've heard us hint a bunch of times. Yeah, that we have instruments that are going to help with MTP fusion. If I had to ask all of you what the number one thing is positioning. It's the most difficult part of the surgery. Throw a nose K-wire freehand. We have been working steadily with the engineers, coming in with some brilliant tools and techniques that will help you get through that step quickly. And I think that is what else is next. We're going to study and research this. There's going to be, just like Treace does everything, there'll be prospective collected information that you can see at the podium. So we're excited that this is the next era of SpeedPlate technology, next era of Treace. It fills out the full complement of the 4 classification scheme that came up with at the beginning of this era. So Treace continues to help give you the tools you need to do surgery the way you need to. What are you going to see? You're going to see a bunch of webinars. You're going to see a bunch of seminars this year available. You'll be targeted towards with your reps. Peer-to-peers are always available as well, for people like me and James to talk to you, as well as the whole complement of other Treace experts out there that love discussing cases with you. And I hope that we can help you with, continue to move into this new era and see some exciting things with this plate. Lauren, what else do you got?
Going to open it up to see if there's any other questions that come in. Thank you both so much. Obviously, this is a hugely exciting time for us, launching a dedicated MTP system. As we are on the eve of launch, starting next week, I will ask both of you one question. What are you the most excited about by having this implant system? I'll go to Dr. Boyle first.
Well, I don't know if I can keep it to one thing, in all honesty. I guess the first thing that comes to my mind is the how flush this plate is. You know, the lack of bulk in it, the contour. There's a lot of thought that went into the design you're looking at right there, and those, you know, those louvered curved edges that they added on to the distal end of the plate and the proximal end of the plate are going to make a huge difference. I'm also, the construct I use, it's a single plate with a nitinol staple in the middle and 2 screws that are in the same plane as that staple. And so I am very excited to see how the active compression, is different from the nitinol, and the the energized plate is going to change that completely. I also am excited to see the how this multiplanar fixation with the fast pitch screws is going to make a difference in the healing and how fast it's clinically and radiographically visible.
Dr. Santrock?
Yeah, I think that to me this is a Bob Santrock claim, not a Treace medical claim, but the Bob Santrock claim here is that I perceive my SpeedPlate cases heal faster than my plate and screw cases. Is that the active compression? Did we dial in, the right amount of stiffness and planar control? I think thought went into that to make the SpeedPlate. So right now when I'm doing a biplanar plating, and if that's what you like doing, biplanar SpeedPlates, don't change if you don't want to, but if you want to try this, I think a lot of engineering went into this to match that type of control. And my perception is my patients will heal faster. We'll prove that out over time if it's true or not true. And I believe the surgery will be faster. I'm putting half as many plates in. So I'm just thrilled that the case will be faster. The edges will be lower profile. And I think the engineering will be superior and give my patients the ability to heal quickly, walk right away, and that's how I'm going into this. Of course, I like everything we've talked about with Treace. We do study and transparently report. I can tell you today that our metatarsus adductus paper was submitted to ACFAS, was accepted today as a podium. As a poster, I believe, might have been podium at ACFAS 2025. So Treace continues to allow us to put transparent results out there every 6 months. I think this will make 7 years in a row that we've done this at ACFAS and AOFAS, either podium or poster presentations. So I look forward to this new era. I think it's going to be great.
Love it. One question did come in. Thoughts on fusing both first MTP and IP with arthritis?
I try as hard as I can to avoid that. I think, in my opinion, it also, you have to take into account the age of the patient. I think it's more tolerated in older patients, I would say, but I do try as hard as I can to avoid that.
I agree. I've only had to do it a handful of times for really disastrous situations, so I try not to at all costs. I have not done a like a resection arthroplasty of the IP joint. I've thought about it. Again, age of the patient, activity is going to predict a lot there. Arthroplasty meaning just resection of the joint, not replacement.
I think the number of pseudarthroses at the IP joint, is pretty significant compared to the MTP joint, and it's still going to be stiff and it's tolerated pretty well. But maybe that's our next joint to attack with some sort of micro SpeedPlate or something, because we need better fixation options down there.
Duly noted.
Good idea.
Dr. Boyle, Dr. Santrock, as always, thank you so much for your time this evening. We thank all of you in attendance. As I said, we are on the eve of launch. Please reach out to your local sales representative. If you have cases coming up that you would like to utilize the Speed MTP, reach out to the product management team here at Treace, the medical education team here at Treace. We are here for your peer-to-peers, as Dr. Santrock mentioned. If you want to, pick one of their brains, Dr. Boyle, Dr. Santrock, on these cases, on utilizing the system, we are ready for your cases. So we're excited. Thank you, everyone, so much.
Thank you, Lauren.
Have a good night, everybody.
Have a good night, and happy Thanksgiving.
Happy Thanksgiving.
Have a good night.